Hi folks, this is Paul Merrick here. Today we will be talking about COVID-19 therapeutics with a particular focus on Ivermectin. In terms of disclosures, I really have no conflict of interest and no association with any pharmaceutical company. I would like to thank my colleague, the King Bean, Dr. Bean, who provided me with a number of graphics. So, maybe some of you didn't know, but the US is in big trouble. Yesterday we had over 80,000 new cases. This is a record. And heading into winter, we can expect a disaster. To date, we've had over 223 deaths in the US, and this is probably an underestimate, as we've had in excess of 300,000 deaths so far this year. Just to review, SARS-CoV-2, this is the virus. There's a nuclear protein which we'll talk about. This is the genome, and then this is the spike protein which inserts into the envelope. So SARS-CoV-2 binds to the ACE2 receptor, then a protease tempress-2 proteolytically cleaves the spike protein S1S2. This allows a membrane fusion and infection of the cell. So it's important to note that SARS-CoV-2 can only get into the cell by binding to ACE2. ACE2 is present in the upper airways, the upper respiratory epithelium. It's present in the lung and present in the endothelium. It's not present in other cells, including the red blood cell, and this becomes important. This is the SARS-CoV-2 genome. It codes for 28 proteins. We're particularly interested in the spike protein, and as you'll see, the nuclear protein, which is at the 3-terminal end. The life cycle of SARS-CoV-2, it binds to the ACE2 into the cell. We have these replication complexes where the virus divides, producing genomic RNA, which gets then assembled both in the endoplasmic reticulus and this Golgi complex with budding. It should be noted, as we'll see, the nuclear protein does get into the nucleus of the cell. It should also be noted that in order for the virus to replicate, it needs Golgi apparatus, it needs ribosomes, and endoplasmic reticulum. This is important as red blood cells have neither of these structures, so the virus cannot replicate or undergo protein translation in the red cell. So as we know, the virus is spread by droplet and aerosol spread. It divides vigorously in the upper airway epithelium, the nasal epithelium, reaching very high concentrations, millions per milliliter. Some of these droplets then get aspirated into the lung. This cartoon just makes the point that the virus initially replicates in the upper airway epithelium in these ciliated cells in the nasopharynx, and then aspirated into the lower airway. One should know that there is decreasing infectivity and ACE expression as one goes from the nasal epithelium into the lung. So we're now going to talk about pharmacological management of COVID-19. And what's really important is that treatment is very phase specific. And this concept has been missed by many of the so-called experts in the field. So we have an incubation period of about 4 days, and we notice that viral replication peaks just before the onset of the symptomatic phase. This is the symptomatic phase characterized by fever, malaise, cough, and headache. Many patients then will recover. About 20% of them will then go on to the early pulmonary phase. Note, in the pulmonary phase, we no longer have viral replication. The host is mounting a vigorous immune response. This is a dysfunctional response to the dead viral fragments. Patients at this time become hypoxic, short of breath, with progressive hypoxemia. So it's kind of obvious that you want to use antiviral agents during the earlier phase. Once you get into the pulmonary phase, the virus is not replicating. In this phase of the disease, one needs immune modulating drugs. Again, this is shown slightly differently. Incubation period, the viral symptomatic period, the inflammatory period. This is viral replication and the threshold for PCR detection. Again, the phases of COVID, this is really an important slide. Day 1 here being the onset of symptoms. So for the first 5 or 6 days, patients have fever, cough, malaise. Many of these patients will then recover. However, about 20% go on to the pulmonary phase. Some patients actually improve before they move into the pulmonary phase. Pulmonary phase starts day 7 or 8, characterized by shortness of breath, decreased oxygen levels. Patients then progressively get worse, admitted to the ICU, eventually land up on a ventilator and die. So this table outlines both the failed and successful treatment for COVID-19 by phase of illness. This column is pre-exposure, post-exposure, or incubation period. This is the symptomatic phase, and this is the pulmonary or inflammatory phase. Now, this table is based on what I consider the best available scientific evidence. There may be clinicians out there who disagree with me somewhat. However, I think this is the best evaluation. So this is hydroxychloroquine. It seems in the symptomatic phase, the hospital phase, and the pulmonary phase is of no benefit, a trend to harm in the sickest patients. In terms of the early phase, there is a lot of debate about this. Although there's not strong scientific evidence, there are a group of very vocal people who believe that hydroxychloroquine has a role in the pre-hospital phase. So just to keep the door open, I've put here of unclear benefit, but clearly it's not supported by strong science. Remdesivir, which is a non-specific antiviral agent, was shown to reduce time to recovery in the US studies with no mortality benefit. So this is really not a patient-centered outcome. The newest study demonstrates no mortality benefit from remdesivir. So the role of this agent really seems to be minimal, has no impact on patient-centered outcomes, and is an exceedingly expensive drug. Loperamide, ritonavir, which are two repurposed HIV drugs, have been shown to be of no benefit. Interferon, which acts to improve host immune response against the virus. In an inhaled form, there may be some benefit in the pre-exposure, post-exposure period. We need further data. In terms of the symptomatic phase and the inflammatory phase, of no benefit, and indeed in the sickest patients, there was a trend towards harm. Tocilizumab, which is an antibody against interleukin-6. It neutralizes interleukin-6. Many thought that interleukin-6 was an important mediator of the inflammatory phase of COVID-19. However, that does not really appear to be true, and interleukin-6 has important immune benefits. However, recent 4 randomized controlled trials have failed to show a benefit of tocilizumab. Next we come to convalescent serum. So this is serum taken from patients who have recovered from COVID. So across the world, including the US, thousands of very generous patients have generated and donated their serum. Unfortunately, this has been a futile exercise, and recent data suggests this is of no benefit. And there is a physiologically good reason to explain this. And in the category of convalescent serum, we should include monoclonal antibodies. However, we don't have any studies on monoclonal antibodies, so they don't appear on this table, which only include published studies. In terms of corticosteroids, we know that in the symptomatic phase in patients who do not require oxygen, there's a trend to harm. However, there's a marked mortality benefit in those patients who require oxygen or mechanical ventilation. So as you can see from this slide, we're in a rather pitiful situation. There is really only one drug which has shown a mortality benefit for COVID-19. I need to repeat that because this is an important concept. There's only one drug which has shown a mortality benefit for COVID, and this is for patients in the inflammatory phase. So we're going to just briefly talk about convalescent plasma. So this is a study recently published in the British Medical Journal. The conclusion was convalescent plasma was not associated with a reduction in progression to severe COVID-19 or all-cause mortality. This was a well-powered study, so it appears that the results are convincing. Now, one should recognize that monoclonal antibodies act similar to convalescent plasma, so it would be no surprise that monoclonal antibodies have a similar result. So the question is, have any patients actually benefited any disease from convalescent serum or immune plasma? So as we know, this is the only study published in the last 40 years which has actually demonstrated efficacy of immune plasma. So the title of this article, published in the Lancet in 1979, Efficacy of Immune Plasma in the Treatment of Argentinian Hemorrhagic Fever, an association between treatment and a late neurological syndrome. For those of you who aren't familiar with Argentinian hemorrhagic fever, which would be most of us, this is a viral hemorrhagic fever that has a very high mortality, and this is a blood-borne infection. Importantly, so in the summary of this study, in a double-blind trial, patients with Argentinian hemorrhagic fever treated with immune plasma within 8 days of onset of the disease had a much lower mortality than those given normal plasma. Some patients treated with immune plasma developed late neurological complications. So as far as we are aware, this is the only study showing a benefit of immune plasma. And actually it's not a mystery that immune plasma or convalescent plasma doesn't work. So immunoglobulins or convalescent plasma with IgG or monoclonal IgG antibodies, these are very big proteins. These proteins, when given intravenously, okay, and the point is intravenously, circulate in the circulation with very little leaking out into the tissues. It needs to get into the tissues, as you'll see, to be transported onto the epithelial surface. So this is the epithelium here, this is the submucosa. So what normally happens is you have B cells, you have plasma cells, you have plasmablasts. These are cells in the submucosa which produce immunoglobulins. Okay, so they produce them in the submucosa. These immunoglobulins then bind to receptors on the basal surface of the epithelial cell and then are transported to the surface and the lumen. So that's how they act. So it's this high concentration of immunoglobulins which then migrate to the surface. It would seem unlikely that giving monoclonal antibodies or convalescent serum intravenously would actually get where you wanted to get, and then therefore be completely useless. However, it is possible that if you give monoclonal antibodies or nanobodies as a nasal insufflation, so you shove it up the nose and insufflate it into the nose, it may get into the nasopharynx. So there is a potential for repurposed or nano antibodies given locally in the nose to have an effect, but giving it intravenously would seem to be a failed strategy. So now we're going to focus on ivermectin. As you know, ivermectin kills worms and parasites and other godly devices, godly creatures. So how does it work? Ivermectin binds to the GABA-gated chloride channel, and that is a mouthful. Anyway, it's a GABA channel on the muscle and nerve cells. It allows chloride into the cell and causes the cell to become hyperpolarized. Once the cell is hyperpolarized, it cannot generate an action potential, so it paralyzes the nerves and muscles of the worm, and the worm dies. Now, ivermectin is used in veterinary medicine. It's part of heartworm, and it's used for cattle and swine. So I'm pleading to the folks out there, please do not go and buy ivermectin outside from one of these pharmacies or veterinary dealers. Ivermectin should be prescribed by a physician under the care of a physician and supervised by a physician. It is extremely dangerous if folks out there start buying ivermectin and self-dosing themselves. So please don't do this. This should be done under the direction and supervision of a physician. So what about ivermectin in humans? It was first used in 1987. Over the past 3 decades, approximately 4 billion doses have been distributed. Most of these have been for the treatment of river blindness. It's a highly soluble molecule, so it circulates well and penetrates tissues and organs. It's metabolized by the liver, very little excreted in the urine, has a relatively long half-life, which then means that you can dose it once a day. As we said, selectively binds to glutamate-gated chloride channel in the invertebrate nerve and muscle cells. It's used for a whole host of parasitic infections, most commonly river blindness, which is onchocerciasis, strongyloides, ascaris, scabies, lice, and a whole host. What is interesting about this molecule is that it's been shown to have broad-spectrum antiviral activity against a host of viruses, both RNA and DNA. It seems to be extremely safe with very minor side effects, including pruritus, which is scratching or itchiness, fever, and rash. It's likely that many of these side effects are related to the death of the parasite. So, in terms of SARS-CoV-2, this was an early study demonstrating that ivermectin inhibits replication of SARS-CoV-2 in an in vitro experiment. So with a single addition of ivermectin to virus cells infected with SARS-CoV-2, they were able to demonstrate a greater than 5,000-fold reduction in viral RNA. So how does ivermectin work as an antiviral? So this is one of the theories postulated by these authors and supported by very good scientific data. So what happens, and this is a really truly mysterious thing, is that SARS-CoV-2 protein, and in this case it seems to be the nuclear capsid protein, binds to what are called important proteins, important alpha and beta. And this allows these proteins to go through the nuclear pore and into the nucleus. So proteins can't just get into the nucleus. To get into the nucleus, it has to go through this nuclear pore, and it's achieved through these importance. The nuclear capsid protein binds to these importance and gets imported into the nucleus, where it causes havoc. It causes cycle arrest, which in most cells is not an issue, but has a marked effect on transcription and DNA binding sites. And particularly it switches off interferon. What happens with ivermectin? Ivermectin binds these important proteins, preventing the SARS protein binding to these importance, and therefore blocking entrance of the SARS-CoV-2 protein, in this instance the nuclear capsid protein, into the nucleus. However, it's likely that ivermectin acts via other mechanisms. This study shows that it binds avidly to the spike protein, the receptor binding domain, and therefore preventing SARS-CoV-2 attaching to the ACE receptor. This is a second study which demonstrates very similar findings. However, in this study they found that the combination of ivermectin and doxycycline work synergistically to block viral entry. So ivermectin showed perfect binding to the spike receptor binding domain. In addition, ivermectin had demonstrated significant binding to the RNA-dependent RNA polymerase. This protein is essential for viral replication, so it blocks entry into the cell and it blocks viral replication. So with that background data explaining the basic science and how this drug may work, what do the clinical studies show? So a number of these studies have been completed. They have not been published in a journal as either a preprint or a final journal. However, this is an important study which is now listed in clinicaltrials.gov. So this was a randomized double-blind study, which is important because many of the experts who live in the ivory tower and don't look after patients absolutely insist that the only study of any value is a randomized controlled trial. So what do we have here? A randomized controlled trial in which a reasonable sample of patients were randomized to ivermectin 12 milligrams, one dose, or doxycycline 100 for 5 days versus standard of care. What did the study show? This is the ivermectin and doxycycline. This is the placebo. Early clinical improvement, 60% in the ivermectin group, 40% in the placebo group, highly statistically significant. When we look at clinical deterioration, 8.7% in the ivermectin group, 17% in the placebo, again highly statistically significant. One of the things we're looking at is, since this is an antiviral agent, you want to see the speed or how long the patient remains PCR positive. If it's an effective antiviral, it should shorten the duration of viral shedding. So you can see here persistent PCR positive, 7% versus 20%. So significantly reduces viral shedding, highly significant. Adverse effects were minor in 2 patients. The mortality was low, 0 versus 3, primarily because they enrolled patients that only had mild to moderate disease. Then we have the ICON study. This was done in 4 hospitals in Florida. This was an observational study, propensity matched, so they had patients who got usual care versus a group of patients who received ivermectin. The demographics are very similar to what we see generally in the US. What did they find? Again, looking at mortality, significant reduction in mortality, 15% versus 25%, highly significant. Mortality in the severe group, 38% versus 80%, obviously highly statistically significant. In terms of extubation, a trend towards earlier extubation, but not significant. When they did propensity adjusted and covariate adjusted mortality, you can see the odds ratio was 0.27. So a very significant reduction in the risk of death. This is again another observational study done in Bangladesh, where they compared 115 patients who received ivermectin to a control group. One should note that the age of the patients was reasonably young. What about the outcome? Disease progression, 2% versus 15%, highly significant. Requirement for ICU care, 1% versus 8%, highly statistically significant. Again, we're looking at viral clearance, 4 days versus 15 days, highly significant, demonstrating that this is a very effective antiviral agent. Duration of hospital stay, 9 versus 15, highly significant. In terms of mortality, 1% versus 7%, again, highly significant. So we have now three studies demonstrate that it improves the rate of improvement, increases viral clearance, and 2 studies showing a mortality benefit. This is the 4th clinical study. It's limited by the small size of patients in the ivermectin group and the generally low severity of illness. So overall, there was no difference in outcome. However, again, when you looked at time to PCR negative or viral clearance, the ivermectin group significantly reduced time to viral clearance. And when we look at length of hospital stay, significantly shorter with ivermectin versus control. So we have in all now 4 clinical studies, all demonstrating a significant benefit from ivermectin. Well, what about prophylaxis? So this is a randomized, non-blinded time series study in which healthy volunteers who were negative for COVID were included in the study. I believe these patients may be healthcare workers, and they were randomized to ivermectin oral drops or placebo. What did they find? 131 patients, the ivermectin group, who used ivermectin in addition to standard PPE. 0 patients developed clinical disease or became PCR positive, compared to 11.2% in the 98 patients who did not receive ivermectin. This is a second prophylactic study. So this is a really interesting study. So what they chose is asymptomatic family members who were close contacts of patients who had COVID-19. So family contacts are a very high-risk group. So they took a large group of patients. They received randomized to placebo or 2 doses of ivermectin. What did they find? 203 patients versus 101. 7.4% conversion infection rate versus 58%. I think this is a highly significant and very important finding. So, what do we know about ivermectin? We know that in prophylactic dose, 150 milligram per kilogram once a week, it's very effective in protecting against SARS-CoV-2. In terms of patients who have COVID in the viral replicative phases, it seems to have an important effect in hastening recovery, decreasing viral shedding, and improving mortality. The dose is 150 to 200 mics per kilogram per day. We actually prefer a standard dose, which turns out to be about 12 milligrams per day. So we give 12 milligrams up, says here up to 4 doses, but usually 2 doses, the first day and then the second or third day, dose of 12 milligrams. What's important to note is it's safe. It's been used for almost 40 years. The side effects are very rare and usually quite mild. So if we go back to our initial table, where the only drug of any benefit was corticosteroids, we now have an exciting addition to this table, with ivermectin being beneficial in the pre-exposure, post-exposure incubation period, being of benefit in the symptomatic phase, and it's likely to be of benefit in the early pulmonary phase, i.e. when we still have viral replication. So it seems to be a very effective antiviral agent. However, I think we need a bit of caution here, and that we need additional studies. So I think that the evidence is quite strong and tantalizing, but I think we need more evidence. And as we're entering into this catastrophic time, I think we urgently, as a major priority, require the powers that be to seriously study ivermectin as a useful drug to control this deadly disease. Just to reinforce that treatment is phase specific and probably a combination of agents rather than single therapy alone. This is now our revised phase specific therapeutic plan. So incubation, symptomatic, early pulmonary, late pulmonary phase. This is the viral replication, antiviral, anti-inflammatory. So interferon alpha may have a role in the early phase, particularly in inhalational form. Methylprednisolone is the corticosteroid of choice for the inflammatory phase. Aspirin has a role in this phase to limit clotting complications. We prefer full dose anticoagulation in the pulmonary phase. As we see, ivermectin can be used in the incubation period or post-exposure period, the symptomatic phase, and probably the early pulmonary phase where we still may have some viral replication. And then quercetin and vitamin C seem to probably play an important role in all phases of this disease. So with that, I thank you for your attention, and hopefully this will be an ongoing exercise. Thank you.